Welcome on MQR AICUG TV. You are watching us on the second day of the conference, and with me is Dr. Ajay Bhardwaj. He is a founder of Avni Health at New Delhi, and we are going to have a conversation with Dr. Bhardwaj on the topic of emergency obstetric care. Sir, may I begin with the first question, like emergency obstetric care. When did emergency obstetric care begins and why?
Okay, firstly, thank you very much for having me on this show, and good morning to all the colleagues who are out there and perhaps watching this show as well. It's a delight to be here, especially at this entire setup which has been made up by MCure, and
sir.
thank you very
Thank
much
you.
for that. When I talk about emergency obstetric care, I talk about the program as such, and the program began somewhere in 2005. Because before 2005, if you look at all the indicators related to maternal health, especially MMR, we found that the MMR was as high as 254, and which is when and it translated into almost 56,000 maternal deaths across the country, which translated in almost about 1 death per 5 minutes on account of pregnancy, which is not a disease. So why should a woman die on account of that? Is the thought process that we had at our end, including all the stakeholders with the program. So keeping that in mind, that a needless death on something which is manageable with proper training and with proper obstetric care, a woman should not die, and so should the child also have a healthy life, and so should the family have a healthy life as well. And that is one of the prime reasons why EMOC came into being, and Government of India ensured that the funding for the same was provided. We had stalwarts like Dr. Sadhna Desai, Dr. Prakash Bhatt from Foxy, who led the championship, and we had almost about 34 medical colleges who partnered with us to take this initiative further. So that's where EMOC came about, and that's one of the prime reasons that EMOC, as a program was implemented across the country.
So 5, that's a quite serious number, sir. I mean, 1 in 5 is a quite serious number. So do we have some protocols for the emergency obstetric care
Yes,
that has been outlined by Foxy or for any body?
Yes. We have a complete curriculum for a 4-month duration, during which MBBS doctors from the medical facilities across the public health facilities are trained. It's a 2-level training program, out of which 6 weeks are didactic and anatomical model and observation in the medical college, followed by 9 weeks at the district hospital, where the practicum and the actual training takes place hands-on, and they are expected to complete an X number of cases. And during all this period, a 4-month period, there are 3 exams, tier 1, tier 2 and tier 3, and at the end of the tier 3, which includes a major examination with an external involvement, the medical officer, if they score 85% in the overall exams, all 3 put together, they are awarded a certification, and this certification
really good,
entitles them to carry on the work that they have learnt, including C-section and managing all obstetric emergencies, so that the mother doesn't die should she arrive at his or her hospital to take care of that.
That's really sounds interesting, sir, and I think fellow gynecologists and obstetricians who have arrived in this conference, they would really take a very good message. Where do we exactly stand on EMOCs right now in our country? Sir, do you think that EMOC stands up to its promise or its expectation that it has outlined?
The question, whether it stands to its promise or not, could be also asked in another way. A promise for whom? Is it the promise for us sitting here? Is it the promise for the government? Is it the promise for the MBBS doctor trained? Or is it the promise for the mother or the child, the family, the country or the world? So to answer that question, yes, it has lived up to its promise. It has been going on since 2006. It's almost 11 years now. The program implementation across all the states. We have trained about 1800 medical officers in this particular program over this duration. We have set up 34 master training centers and program training centers across the country. We have 285 district hospital training sites where the second leg of the training takes place. And when you look at the overall numbers in terms of achievement as far as reduction in MMR goes, so EMOC is a key component in all the initiatives that have been taken by Government of India and
nice.
different stakeholders with the advent of NRHM and NHM now. So EMOC has contributed to the entire thing, and we see the numbers declining from an SRS data of 2001-3 where the MMR was 254. The MMR today as it stands on 2011-2013 is 167.
Oh, that's nice.
So it's definitely dropping, but if you ask me and you, what's the maternal mortality we want in our houses?
Yes.
The answer would be zero.
Zero,
So why should 167 also die? So
Right.
A lot of work still needs to be done, and we are confident that fellow gynecologists and obstetricians will continue advocating and making sure this is out there, and people continue contributing for this particular program and saving the mothers.
Absolutely, sir. Sir, from the program that you just outlined, is it only for the government practitioners, or is it that the clinicians in practice, I mean in a trade practice, can they join to this program?
Currently,
Because I think most of the patients from the periphery would be referred to the tertiary care center at a very late stage of their complications, and then the maternal mortality is occurring. So to remove that or reduce that number of 167, do we need to also partner with the private practitioners?
I think it's a very valid question, and the priority for us and for Government of India to start with was making available the service delivery at the point of care, which included the PHCs, CHCs, and district hospital and above. Because what was happening is many times there was a non-availability of a trained gynecologist in that particular area. So the only doctor dependent was an MBBS doctors who are at a medical officer and posted over there. So it was critical that those doctors were trained and brought onto the fold so that they start contributing to this overall reduction. So the initial target was that. We are trying to advocate with the government now that it is almost 11 years into the program. The program should be opened up to private gynecologists or private doctors who are in the periphery to prioritize, followed by certain other areas that we could prioritize and get them on board. Essentially, see, gynecologists and obstetricians know their science, but the science is changing continuously. So this will give them an opportunity to come back to the drawing board and go through that. So the course may not be for 4 months, it may be reduced. So we are trying to talk to the government and trying to see if it is possible for us to involve the private practitioner who can come and do this particular course, for which who will pay is a big question, but we'll cross that bridge when we have to come to that.
Fine, sir. Thanks for sharing your views on this very important aspect of emergency obstetric care, and I wish and MCure wishes that this program further succeeds and we are able to reduce the maternal mortality in our country, which is a very doable thing. I mean, if we all get together, we can definitely work towards it.
Sure.